Right now, as you listen to my voice, there's a tiny, delicate chain of bones vibrating inside your skull.
Yeah, really tiny.
Right, and it's a mechanical system that is so precise, it can pick up, the rustle of a leaf from across a quiet room.
Which is incredible, but also
unbelievably fragile. I mean, a sudden change in cabin pressure on your next flight, or, let's be completely honest here, a rogue cotton bud after a shower, could literally snap it in half.
Oh, absolutely. It's a profound vulnerability. I mean, we walk around every single day relying on this microscopic engineering, totally unaware of how easily it can fail.
Yeah.
And when that system does break, the way surgeons have to go in and fix it is, well, it's nothing short of reconstructive architecture, performed in a space that's smaller than a dime.
Which is exactly our mission for this deep dive. Today, we are exploring the incredible, fragile, and highly repairable mechanics of human hearing.
It's a fascinating topic.
It really is.
Yeah.
We're pulling insights from a definitive medical text background essential to our otolaryngology head neck surgery. And we want to understand exactly why the middle ear fails and how surgeons use everything from human fascia to perfectly calibrated titanium to rebuild it.
Yeah, the materials alone are wild.
Okay, let's unpack this.
Yeah.
To really understand the surgery, we have to start at the front door of the middle ear, or the tympanic membrane, or as most of us know it, the eardrum.
That front door analogy is perfect because the tympanic membrane is it's the absolute boundary line. It is the sealed barrier between the outside world, so your ear canal, and the pristine, sterile environment of the middle ear.
Right.
So when we talk about ossiculoplasty, we're talking specifically about the surgical repair of that drum head.
And to work correctly, that drum head needs to be tightly stretched and totally intact, exactly like the cone of a high-fidelity speaker. But things go wrong, obviously. A hole in that drum head is called a perforation. And I was surprised to read that the number one cause of this is not physical trauma. It's not someone jabbing something into their ear.
No, it's actually infection.
Wow.
Yeah, acute otitis media. So a severe middle ear infection is the most common culprit. If you think about the physics of an infection in a completely sealed room, as fluid and pus build up behind the eardrum, the pressure just continually rises. The eardrum stretches and stretches until mechanically the tissue just has to give way, ruptures just to release that pressure. Basically, yeah. And then of course you do have physical trauma causes too. Direct strikes or barotrauma, if you're scuba diving and you descend way too fast, the pressure differential between the water pushing in and the air in your middle ear gets so extreme that the drum just pops inward.
Ouch. But what I actually found most surprising were the iatrogenic causes, like perforations caused by medical interventions.
Right, the ventilation tubes.
Yeah, the grommets, which are incredibly common for kids with chronic ear infections.
It's a calculated risk, Yeah. Those tiny plastic tubes are placed right through the eardrum to allow that fluid we talked about to drain.
Right.
And if a short-term tube is used and it eventually falls out on its own, there's about a 2.2% risk that the hole never closes.
Okay, that's not terrible.
No, but if a long-term tube is used, that risk of a permanent hole jumps to up to 16%.
16%?
Yeah.
Just because the body gets confused, right? When you leave a foreign object like a plastic tube in the eardrum for years, the skin cells actually grow down and around the edges of the tube.
That's exactly what happens.
So when you finally pull it out, the edges of the hole have essentially healed themselves. The body doesn't even register that there's a gap left to close.
Right, the biological signal to knit that tissue back together has basically been turned off. And when you're left with that hole, the symptoms are pretty immediate. You deal with chronic discharge and obviously hearing loss.
And the text points out that the location and size completely change the auditory impact, right?
Yeah.
The hole is in the posterior superior area.
The top back section.
Right, the top back section of the drum. That disrupts the mechanics much more severely. It causes way worse conductive hearing loss. And as the hole expands, you start losing those high frequencies.
Yeah, and if the trauma is severe enough to cause a complete discontinuity, meaning the entire mechanical chain behind it is broken, you hit a ceiling.
The ceiling.
Yeah, you max out at about a 60 decibel conductive hearing loss, which essentially means normal everyday conversation suddenly sounds like it's happening underwater 3 rooms away.
Wow. But wait, I have to push back here on the necessity of surgery for this. Because the statistics show that 70 to 80% of these perforations actually heal spontaneously within 30 days.
They do.
So if the vast majority of these blown out speaker cones just naturally knit themselves back together, why would anyone ever risk microscopic surgery?
Well, it comes down to what happens when you fall into that 20% where it just doesn't heal. You're suddenly living with a really chronic, debilitating condition.
Right.
One of the primary indications for myrinoplasty is recurrent otorrhea, which is persistent, messy ear discharge. And this is an absolute deal breaker if the patient relies on a hearing aid.
Oh, I didn't even think of that.
You simply cannot place a highly sensitive electronic hearing aid into a wet, actively discharging ear canal. It'll completely destroy the device, and it'll make the infection worse.
That makes total sense. You're essentially trying to plug an open wound with plastic and batteries.
Precisely, it's a disaster. Another major reason for surgery is the size. If the hole takes up more than 25% of the eardrum, the hearing loss accelerates. And those massive perforations, they very rarely close on their own.
Okay.
There's also this danger of retraction, where the weakened eardrum basically gets sucked inward, and it creates a pocket that traps skin cells. That forms a destructive cyst called a cholesteatoma.
Which sounds awful.
It is. And finally, you have purely social or lifestyle indications.
Right, like swimming. I read that. If you had an open perforation, getting unsterile pool water or ocean water into your middle ear is just a fast track to catastrophic infection.
You're essentially barred from the water.
Yeah, so repairing it literally gives you your life back. But if a surgeon decides it is time to close that hole, the next obvious hurdle is figuring out what exactly you use to patch a microscopic vibrating drum head.
And this is where we see a true masterclass in tissue engineering. The materials they use range from the brilliantly simple to the wildly complex.
Yeah, like paper.
Exactly. For very small perforations, surgeons might just use a paper onlay. It's a simple outpatient procedure. They literally place a tiny sterile paper patch over the hole to give the cells a bridge to grow across.
A literal piece of paper. It's exactly like putting tape over a tear in a speaker cone.
It really is. But for larger holes, they have to turn to autologous grafts, so tissue harvested from your own body. And the undisputed gold standard here is temporalis fascia.
The temporalis fascia. That's the tough fiber sheath covering the muscle right above your ear, right?
Yes. And from a surgical standpoint, it's a dream material. It's abundant. It's right there in the same surgical field, so the surgeon doesn't need to make extra incisions elsewhere on your body, and its basal metabolic rate is incredibly low.
Meaning the body accepts it without throwing some huge immune response, because it's already yours.
Right. But they can also use cartilage, the tragus, that little stiff bump of cartilage right in front of your ear canal.
Oh yeah, I'm touching that right now.
Yeah, it's a perfect donor site.
Yeah.
For massive holes that take up more than half the eardrum, they use a composite graft. They keep the cartilage and its surrounding perichondrium tissue together for extra structural integrity.
Got it. And if you can't use your own tissue for some reason, they use alloderm, right? Which is an immunologically inert human allograft. Essentially, it's processed donor tissue. Yeah. And it still boasts an impressive 87.5% success rate.
The materials are fascinating, but the techniques used to actually slip these patches into place are just as critical.
Right.
You have the underlay technique. That's where the surgeon tucks the graft completely underneath the remaining eardrum, and they support it from the inside with dissolvable packing.
Yeah.
Then you have the overlay technique, which is far more delicate. The surgeon literally separates the microscopic layers of the eardrum itself. They peel up the outer skin layer and sandwich the patch directly between it and the inner collagen layer.
That sounds impossibly precise. And for smaller repairs, there's the push-through technique, where they just shove the dissolvable dressing and the graft right through the hole and then pull it back slightly so it anchors against the inside rim.
Yes, very efficient.
But here's where it gets really interesting. There is a specific method called the butterfly technique. Have you seen this?
Oh yes, it's brilliant.
For small perforations, so under 6 millimeters, the surgeon takes a tiny circular disc of cartilage and cuts a groove entirely around its outer edge. Then they simply push it into the hole.
Like a button.
Exactly. The edges of the cartilage splay out and then literally snap into place, gripping the edges of the hole exactly like a rubber grommet or a button going through a buttonhole. It's just pure pure mechanical satisfaction.
It is an incredibly elegant solution, though it does carry a slight caveat. It has about an 11% risk of triggering mild myalgitis.
Which is inflammation, right?
Yeah, inflammation of the eardrum. But that generally resolves itself within 3 months. However, returning to materials for a second, there is one category that really pushes the boundary: xenogenous grafts.
Right.
This is tissue harvested from entirely different species, specifically equine or bovine pericardium, the tough sac that surrounds a horse or cow's heart.
Okay, and this is where I really have to pause and question the logic here. Because if we have our own temporalis fascia right above the ear, perfectly matched to our own biology, why on earth would a surgeon choose to patch a human eardrum with cow heart tissue?
It sounds strange, I know.
Especially when historical data shows that animal tissue has a significantly higher failure rate than our own autologous grafts.
What's fascinating here is how the field is actively trying to rewrite those historical failure rates using advanced biochemistry. You're absolutely right, a simple animal graft isn't ideal. But surgeons are now combining these xenogenous grafts with basic fibroblast growth factor, or FGF.
Okay.
They use it alongside a biological delivery medium called adelocollagen.
So they aren't just like putting cow tissue in there and hoping for the best.
Not at all. FGF is a wildly powerful signaling protein. When they soak the animal tissue scaffold in FGF, they are essentially installing a chemical beacon. Yeah. It actively recruits the patient's own cellular machinery. It signals the blood vessels and the skin cells to migrate across this foreign scaffold and rapidly multiply.
Oh, wow.
The results are highly encouraging. It's a complete shift from simply patching a hole to actively directing the body to regenerate its own tissue.
They're biologically tricking the ear into rebuilding its own drum head. But patching that front door is really only half the battle. Because what happens is the surgeon beautifully reconstructs the eardrum. The patient wakes up, the drum is totally airtight, and they still cannot hear a single thing.
That is the nightmare scenario.
It means the trauma didn't just break the window, right? It destroyed the furniture inside. And that requires moving deeper into the skull to perform an ossiculoplasty.
No.
The repair of the middle ear bones.
Right, the malleus, the incus, and the stapes. The ossicular chain, these are the 3 smallest bones in the human body, and their job is far more complex than just simply conducting a vibration.
Right, because of the fluid.
Exactly. Sound hits the fluid in your inner ear, and it naturally wants to bounce right off. To overcome that fluid resistance, these 3 tiny bones act together as a biological hydraulic press.
Hydraulic press.
Yes. They take the large, low-pressure vibrations of the eardrum, they compress them down into the tiny footprint of the stapes bone. It amplifies the force of the sound by roughly 20 times.
So if any part of that microscope's hydraulic press breaks, your hearing just instantly plummets. Sometimes, the text notes this is congenital, happening in about 1 in 15,000 births where the bones are fused or deformed. But far more often, this breakdown is acquired over time.
And the relentless driver of that acquired damage is chronic suppurative otitis media, so long-term chronic middle ear infections.
Right.
The constant presence of inflammation, fluid, and these destructive enzymes slowly just eats away at the bone itself. And the single most vulnerable point in this entire chain, the spot that erodes first and most often, is the incudus-pedial joint, the ISJ.
And why is that specific joint so incredibly fragile? I mean, why does it always break there?
It comes down to vascular geography.
Okay.
The blood supply to the ISJ is notoriously tenuous. It basically sits at the very end of the circulatory line for those bones. So when massive inflammation hits, that weak blood supply is easily compromised.
Oh, I see.
The bone tissue dies, the joint dissolves, and the connection between the second and third bone simply vanishes. The hydraulic press is broken.
To figure out exactly how badly that press is broken, surgeons use this mapping system called the Austin cartouche classification.
Yes, essential tool.
It essentially takes inventory of which structural pillars are still standing in the middle ear. So the most common scenario, making up about 60% of cases, is classified as M plus S plus, meaning the handle of the malleus is still there and the superstructure of the stapes is still there.
Right.
The pillars are intact, the surgeon basically just needs to build a new bridge between them.
But then you have the rare, highly complex cases like M minus S minus, which accounts for about 8% of patients.
Is that bad?
Very bad. In this scenario, both the malleus and the delicate arch of the stapes have completely dissolved away. So the surgeon is staring into this cavernous middle ear with virtually nothing left to anchor a prosthesis to.
And the materials they use to build these bridges, they actually have a pretty dark history.
They really do.
For a while, they used alloplastics, so porous plastics like plastic pore, but those carry a massive risk of triggering aggressive inflammatory reactions. The body just flat out rejects them. They also heavily utilized homografts, which are tiny replacement bones harvested from human cadavers.
Which, to be fair, were highly effective from a mechanical standpoint, but they carried a catastrophic hidden risk.
Right, homografts are now entirely banned in the United Kingdom due to the risk of transmitting CJD, or mad cow disease, which is, I mean, the idea of catching a fatal brain brine from transplanted ear bone is terrifying.
It is absolutely horrifying.
So today, the absolute standard is metal, specifically incredibly precise titanium implants. But this raises a mechanical question for me. If titanium is biocompatible, it's lightweight, it's perfectly rigid, why do surgeons still sometimes bother with, like, bone cement or reshaping eroded bone? Why not just drop a titanium piston in there every single time and call it a day?
Because of the uncompromising laws of physics that govern the middle ear. You just cannot drop a piece of metal in and expect it to vibrate perfectly.
Really?
No. An ossiculoplasty demands a rigid piston-like arrangement with excellent coupling at both ends, but absolutely minimal tension.
Yeah.
If a titanium prosthesis is even a fraction of a millimeter too long, it pushes too hard against the inner ear fluid. That damps the vibration and leaves the patient with inferior hearing. It has to be sized perfectly. And there is a much more severe physical constraint regarding the eardrum itself.
Right, it's a friction problem. If you put a hard, unyielding titanium piston right up against a thin, vibrating piece of skin like the eardrum, it's exactly like wearing a tight pair of leather shoes without socks.
That's a great way to put it.
Eventually, the constant friction is going to cause a blister. Or in this case, the metal will literally erode a new hole right through the eardrum from the inside out.
Which completely defeats the entire purpose of the surgery.
Right.
So to prevent this, the surgeon must introduce a biological buffer. They harvest a thin slice of cartilage and place it securely over the head of the titanium implant. Exactly, this cartilage cap acts as the sock. It absorbs the friction and prevents the metal from extruding through the drum. It is a wildly delicate balancing act of biology and mechanics. But even with perfect technique, there's one absolute anatomical rule.
What's that?
The single most important predictor of surgical success is whether the patient still has their stapes superstructure. If that tiny arch is present, the chances of restoring robust hearing are just exponentially higher.
Which brings up the ultimate variable, really, the patient themselves.
Always.
A surgeon can execute this microscopic ballet flawlessly. The cartilage cap is perfect, the titanium is sized to the exact millimeter. But how do they actually predict if this is going to work long term for the person sitting in front of them?
They calculate the odds using a tool called the middle ear risk index, or the MERI.
The MERI score.
Yeah, it assigns a numerical severity score to various environmental and biological factors to predict whether an ossiculoplasty will actually survive.
And the MERI score looks at a whole host of variables, right? Like, are you a smoker? That immediately adds 2 points of risk because smoking destroys the microvasculature needed for healing.
Oh, absolutely.
Have you had previous ear surgeries? That's another 2 points. And they heavily weight a metric called the Bellucci classification, which fundamentally just asks, is this ear dry or is it wet and actively discharging?
Because a perfectly dry ear scores a 0. It's the ideal environment.
Right.
A persistently wet ear tells the surgeon that the underlying mucosal lining is diseased. That makes it a highly hostile environment for a delicate graft or a titanium implant to take hold. They also look very closely at the patient's age and timing, specifically regarding the eustachian tube.
The eustachian tube, that's the pressure release valve that connects the middle ear to the back of the throat.
Exactly. In young children, that tube is almost entirely horizontal, meaning it drains poorly and it regulates pressure inefficiently. That's why kids are so prone to ear infection.
Oh, that makes sense.
But around age 7, the anatomy matures and the tube angles downward. That allows gravity to assist with drainage. So many surgeons will outright refuse to perform these complex reconstructions until a child is at least 7.
Wow.
Because if you build a pristine new eardrum, but the eustachian tube behind it still doesn't work, the vacuum pressure will just suck the new drum inward and completely destroy the repair.
The plumbing behind the wall has to work before you paint the room.
Precisely.
There are also absolute red lines, right? Strict contraindications where surgery is just off the table. The presence of a cholesteatoma is a hard stop for a myrinnoplasty. Because, as we mentioned, a cholesteatoma is a destructive cyst made of squamous epithelium, basically skin cells growing where they shouldn't. Every single microscopic trace of that cyst must be excised before you even think about sealing the eardrum.
Yeah, because if you trap just a few aggressive skin cells behind your shiny new graft, they'll just silently keep growing, they'll release enzymes, and start eating away at the skull bone all over again.
Terrifying. And we have to talk about the reality of the long-term data, because complications happen.
They do.
Even with flawless technique, we see issues like iatrogenic cholesteatomas from those trapped cells, or persistent myringitis. When you look at the raw data for adult myrinnoplasties, early success rates range anywhere from 60 to 99%.
But the crucial variable is time.
Exactly. Across the board, overall success rates hover around 85% at 1 year post-surgery. But if you track those exact same patients, that success rate steadily degrades to about 78% by year 10.
Yeah, the numbers do drop.
So what does this all mean? Why does a perfectly calibrated titanium piston or a beautifully healed fascia graft suddenly start failing almost a decade later?
Is mechanical engineering just inherently flawed?
If we connect this to the bigger picture, we have to remember the fundamental difference between a machine and the body.
A titanium piston in a car engine operates in a sealed, highly controlled environment bathed in oil. But a graft and an implant in the human middle ear are living in a highly dynamic, constantly volatile environment.
Right.
Over a decade, that ear has to survive you catching the flu, violent sneezing fits, seasonal allergies that inflame mucosa, hundreds of flights with rapid cabin pressure changes, and inevitable minor infections.
The sheer wear and tear of just existing in the world.
Precisely. The mechanical titanium fix is permanent, but the biological environment around it is completely at the mercy of life, which leads to one of the most brilliant, counterintuitive insights in the field.
What's that?
One of the absolute best predictors of whether a complex surgery will succeed on a diseased ear is to look at the patient's other ear.
Their normal ear.
Yeah. If their normal contralateral ear is perfectly healthy, it proves to the surgeon that the patient's underlying biology, their systemic eustachian tube function, is fundamentally sound.
Oh, I see.
It means the diseased ear was just the victim of an isolated chaotic event, like a bad infection or trauma, not a systemic biological flaw that will inevitably ruin the new repair.
The healthy ear serves as the biological guarantor for the sick ear. That is a fascinating perspective. So we've traveled from a simple, violently ruptured drumhead caused by an airplane descent or a childhood infection deep into the skull. We've seen how surgeons use temporary paper, a patient's own muscle fascia, and microscopic titanium pistons topped with protective cartilage socks to rebuild a shattered hydraulic amplifier.
It's an incredible journey.
And we've seen how they mathematically index the risk to ensure their intricate engineering can survive the brutal dynamic reality of the human body.
It truly is a testament to resilience. You are walking around right now with an auditory transmitter that obeys strict, uncompromising laws of physics. And when those laws are broken, we possess the surgical mastery to rebuild the machinery from scratch, provided the surrounding biological ecosystem is healthy enough to support it.
It really makes you hyper aware of every single sound you're processing right now.
This raises an important question. If we look back at the frontier of those non-genous grafts we discussed.
The cow tissue.
Right. If surgeons can use basic fibroblast growth factor FGF to actively signal the body to rapidly regenerate tissue across an animal scaffold, are we looking at the twilight of metal implants altogether?
Wait, really?
It's entirely plausible. Will the next generation of ear surgeries completely abandon the tedious balancing act of titanium pistons and harvested cartilage? In a few decades, surgeons might not use metal at all. They will simply apply highly targeted bioengineered regenerative drops to a dissolving scaffold and literally instruct your body to regrow its own perfectly calibrated living vesicular chain from scratch.
Now that is a profound thought to leave you with. Thank you for joining us as we unpack the tiny, fragile, and absolutely incredible mechanics of human hearing. Catch you on the next deep dive.